think we can begin. Professor Kuala, you can do the introductions.
Good evening, everyone. Today, we are delighted to have Dr. Sood, who is going to talk to us about the intersection between the kidney and cancer. Dr. Sood's interest is onconephrology. It's a field which is coming up quite, extensive right now with the new drugs in the market for cancer. So lots of intersection. I like his title, actually. There's lots of intersection between the kidney and the cancer, and he's going to talk to us about that. Dr. Sood is a well-renowned nephrologist and a physician at the Coast General Hospital. He has his own private nephrology practice at the Mombasa Hospital, and he also is very actively involved in the Kenya Association of Physicians. He was a vice chair previously, also very much involved in the EXACOP program, which is training physicians in this country. So without much ado, I'll hand over to Dr. Sood, who's going to talk to us about the intersection between the kidney and cancer. Dr. Sood,
thank you very much, Professor Kuala, for the kind introduction. Today evening, we are looking at intersection between the kidney and cancer. And this field is actually moving forward so fast because in onconephrology, every morning there is a new drug which targets the cancers. But at the same time, then we are seeing that we are also having a lot of acute kidney injury or involvement of the kidneys. So without further ado, I think we will I have no disclosures. So let us look at this first case. And this is a case of 42-year-old with diabetes, gout, undergoing a radial inguinal orchidectomy for left testicular stage 2 seminoma. He is on adjuvant intent of etoposide, cisplatin, and the planned chemotherapy. So the cisplatin dose will be 100 unless a creatinine clearance is below 60, which will necessitate, if it is below 60, 25% of dose reduction. So on cycle 1, day 1, the patient weight is 77, his height is 57. He reports recent corticosteroid dosing for new resolved gout flare. The lab results are notably for serum creatinine of 1.4, which in millimoles is 123, which is his baseline. So the oncologist gives you a call to ask you which test best reflects this patient's kidney function. So here we are. You can scan the QR code there. I'll give you like 30 seconds and you can pick your answer. Okay, I think we can move on to that. So which will be the best answer to the oncology questions? So some have picked EGFR with cystatin C as the answer. So here the problem is the patient is on steroids. So when the patient is on steroid, the cystatin C is actually affected and will not give you the accurate EGFR level. If you picked estimated GFR creatinine, again, your patients usually are sarcopenic and they will not be able to get accurate calculation with that. If you pick 24-hour urine, then your patients actually will have under or overestimation on this, and C will actually give you the same problems with cystatin C and corticosteroid. So the answer here is 125 iothalamate clearance, though this is actually not readily available in many facilities. So we still stick to the GFR or CKD AP calculation. And the reason for this is you can actually see when you employ calculation based on whether the patient weight is reduced or you are using the body surface area, sometimes you can actually underestimate the eGFR or overestimate it. And when you do that, you actually get increased toxicity if you give a dose which is higher, or if you underestimate it again, you can actually give a dose which is not efficacy and the tumor will still continue. So this is something we'll look at as we move through to find out what is the best way to approach this. So to start with, if you look at the global cancer cases, you will see that worldwide cancer cases are actually projected to increase by 50%. That is from 14 million in 2012 to 21 million in 2030. Now, as we increase the cancer prevalence, then also there is projection of increase in cancer death up to 60%. So these cancer deaths, actually, when you look at where they come from, you will find that your patient who has got cancer most of the time suffers from AKI, is not addressed within the limit, then your patient actually suffers mortality or death. And this is very well demonstrated in Ontario, where they had 163,000 patients undergoing cancer chemotherapy. And they could see that the incidence was actually up to 52 per 1,000 years. So we had the highest incidence in myeloma, bladder cancer, leukemias, and kidney cancers. Now, this is just what we had just discussed in the London, Canada, and it's showing us the survival of your patients will actually be higher if you can prevent them from going into failure. And this is actually dose-related reduction in survival in patients who have cancer. This was also a study done in the ICU patients, just to show you that as you approach acute kidney injury stage 3, you actually have more deaths occurring from these patients, and the mortality is almost 42%. So there is a connection between the mortality, acute kidney injury, and here you find that patients who are on anti-cancer drug, malignancy, radiation, they usually have electrolyte imbalances, they get AKI, and it's actually it's actually affecting every person who is having this. So the risk factors for AKI, when we look at them, you can divide them into hematological malignancies or solid tumors, but then there are certain risk factors which you can predict that your patient is going to have acute kidney injury. And these factors are, if your age is 65 years, you have coexisting heart failure, you have a pre-existing CKD, you are diabetic, you have cirrhosis, hepatic failure, or nephrotic syndrome, or from beginning you have volume depletion. This could be due to vomiting, diarrhea, stomatitis, sepsis. And once you have that, then you can actually see that the prediction for your patient suffering from AKI is actually going to go high with these comorbidities being there. So what are the causes of AKI in cancer patients? Now, the causes are actually interrelated, and you can actually put them whether it is related to therapy or it is related to cancers. So if it is related to therapy, there are a lot of immunotherapies, target therapies, radiation, hematopoietic stem cell transplants. If it is related to cancer themselves, then you can see there is direct invasion, there can be obstruction. Sometimes you can get tumor lysis syndrome or thrombotic microangiopathy. And this, you can have a couple of them actually occurring in one patient. So when we look at these preventive strategies, then you can look at them from the pre-renal, renal, and post-renal aspects. where you can prevent this kidney injuries in patients, especially patients in pre-renal. You will find them because of the chemotherapy. They have nausea, vomiting. Sometimes they can get hepatorenal syndrome, neutropenic sepsis, or capillary leak in these patients. A lot of these patients also take NSAIDs, and you will find this is something which pushes the kidney to acute kidney injury. We can have contrast-induced, which is also one of the problems we tend to see. Many of them will also have post-renal compression or obstructions, post-related or from the tumor itself. So when we look at tumor lysis syndrome, a lot of time you can actually predict your patients what type of risks are on. Anytime your patient comes in with a WBC count of more than 50,000, then these are risk factors for developing tumor lysis syndrome. Massive tumor burden will give you that, an LDH level of more than 50,000. This will tell you that the patient most likely is going to suffer from tumor lysis syndrome. If it is patient-related risk factors, you'll find there is older age, reduced eGFR, there is dehydration. Sometimes you get mediastinal masses. These are patient-related factors which can cause you to have that. Now, how do you place your patients, whether they are suffering from tumor lysis syndrome? You can use your labs, and in your labs, you need 2 or more lab abnormalities from day 3 to day 7 after initiation of the cytotoxic therapy. And here you will find your uric acid is elevated more than 8, potassium is also high, phosphate, and you will have a change of almost 25% from your baselines when you look at that. Clinically, you can actually look at the patient and you'll see these patients are actually having cardiac arrhythmia, seizures, and sometimes sudden death can occur. So we tend to use Bishop grading or clinical tumor lysis syndrome grading, where you could place the patient and you can see that as your patient moves from 0 to 5, then 5 becomes the worst grading, which ultimately leads to death in these patients. So are there any preventive strategies to this? And yes, the answer is yes here. You could give your patients fluids, and here, once you hydrate your patients, it actually helps you a lot in terms of prevention to that. A lot of things can also push you, especially diuretics in these patients. If your patients are actually using diuretics, then they can make it even worse. So urine alkalinization, this was in the old days, people used to alkalize their urine, but these days we have seen that the more you alkalize your urine, you find that there is precipitation of calcium phosphate, which actually form and make it even worse. Apart from that, then you can actually treat your patients. And here we have allopurinol can be used in these patients. Rasburicas can also be used in these patients, and you need to calculate the dose here as 0.2 milligrams per kg per day. At the same time, some of the patients with G6PD is contraindicated to use, but it's not necessary for us to actually investigate for that if your patient is really suffering from high risk of tumor lysis syndrome. Febuxostat is also there. You can use, it is much safer than allopurinol, which you need to renal dose adjust in these patients. Sometimes things can be a little bit on the worst side, and you can put your patients on dialysis in these patients if you are not achieving what is best for the patient. Persistent hyperkalemia, which is actually not resolving with any of the treatments, then you can push them to do your CVVHD or depending on the status, you can choose the modality. So this is what we just talked about, the low risk and high risk patients, how you can prevent them. You just oral hydrate, avoid nephrotoxin. Some authors actually tell you if your patient is on a high risk group, then you can initiate the xanthine oxidase inhibitors earlier, but data is not robust on this, and we see sometimes still the xanthine oxidase accumulate with uric acid. So, of course, we have talked about the hyperkalemia, hyperuricemia, and hyperphosphatemia in these patients. So, there are cancer-associated thrombotic microangiopathies. And in these patients, we can classify them as cancer-related TMAs, and then we classify them as cancer-related or induced TMA. Now, in this category, we have type 1, which is chemotherapy regimens, and type 2, which is anti-VEG agents. So type 3 is actually hematopoietic stem cell therapy-related TMAs. So a lot of cancers you will see will actually give you TMAs, and these are some of the points which you must look for and see that gastrointestinal is one of the cancers which is notorious for this, and you get gastric cancers or colonic cancer. But all the other systems, you can see we have different types of cancers which can also cause the same TMAs. So is there a way for you to differentiate between this TMA is cancer-related or chemotherapy-related TMA? When you look at features, most of these cancer-associated TMAs, 90% will have metastatic disease. But when you look at chemotherapy-induced TMA, may not be present. Again, when you look at DIC, it will be present in 15% of the patients who are cancer-associated TMA, and it is absent in chemotherapy-induced. Even in terms of therapy, you find our patients who are cancer-associated TMA fail to respond to plasmapheresis, but those with chemotherapy-induced TMA, the deficiency responds to plasmapheresis. So we have to compare and see where our patients fall, and this will guide you between the TMAs. Is it cancer-related or chemotherapy-related? So if we dive in chemotherapy, you'll see the type 1s here. Type 1s, usually, the timing is between 6 to 12 months after starting the therapy. But in type 2, can occur at any time after initiation of treatment and may be observed after a prolonged treatment. Dose relationship is actually in type 1 is dependent on dose relationship in comparison to type 2, which there is no dose dependent, and also you will get arteriolar and glomerular capillary thrombosis, where in type 2 you might not get the arteriolar, exclusively glomerular capillary thrombosis. Also, type 1s are irreversible damage. This is increasing morbidity and mortality, and high incidence of acute mortality between 4 months. It's up to 75. Despite drug discontinuation. Okay. While on the other side, you see the recovery after interrupting the medication, the patient tends to have better survival upon stopping the causative agent. So hematopoietic stem cell transplant-related acute kidney injury. Now we are seeing a lot of patients undergoing these therapies where you have a type of donor, whether it can be autologous or allogenic, and then you undergo myeloablative, complete eradication of the marrow. After that, then you will actually see that you are given high dose chemotherapy to ablate recipient marrow prior to transplant, and then there is an infusion session into the recipient. So once you do that, then there are type of hematopoietic cells which are actually going to have a lot of complication or high prediction of kidney injury, which will require dialysis. So myeloablative regime actually has the highest risk, about 19 to 66% of kidney injury, and most likely 17% of your patients will require to go on dialysis, and the risk of mortality is also high. Now, why is it like that? You will find that these are some of the risk factors in these patients. They become dehydrated, they are bound to sepsis, sometimes they get acute tubular necrosis. The drugs they are given for immunosuppressions can actually cause direct nephrotoxicity. You might suffer from tumor lysis syndrome. Of course, other infections can also take opportunity, and the patient is actually going to have very high risk in these patients. Now, look at this, and you'll see that when you are given stem cell transplant, a lot of times there is endothelial damage and you get portal hypertension. This is from the sinusoidal obstruction which occurs, and it can translate to glomerular vasoconstriction, leading you to CKD. But at the same time, there can be acute graft versus host reaction in these patients, and then you get to have proteinuria or TMA formation, and you get glomerular disease, which same time makes them suffer from CKD. Of course, tubular interstitial fibrosis also can occur, especially with inflammatory cytokines, and your patients might undergo radiation at the same time, and you suffer from the chronic kidney disease. So these are very important, the vaso-occlusive disease, acute versus host, and tubular interstitial. Now, sinusoidal obstruction syndrome, actually what we get here is the endothelial cell injury in the hepatocyte damage, which usually complicates in around 10 to 15% of patients who undergo this modality. And it's actually a painful hepatomegaly. Patient suffers from jaundice. You get oliguria, which mimics hepatorenal syndrome. And hemodynamically, you can actually see elevation of the creatinines, and 80% will require dialysis, will also die. So we have a preventive therapy in these patients where you can actually give pentoxiflin, or you can give difibrodide, which is actually going to reduce the anti-inflammatory, anti-thrombotic, and there are questions on it, whether it works or not, but a few trials have used it, and the outcomes are equivocal, actually. Of course, we have talked about thrombotic microangiopathy being one of the complications in these patients with sinusoidal obstructive syndrome, and here, what you need to do is you just withdraw some of the drugs, and you can do your plasmapheresis and rituximab. So host versus graft disease and AKI, almost 60% of the patients in the first 100 days, they will present with rash, diarrhea, which gives you a pre-renal failure. Of course, we have talked about sinusoidal syndrome and liver function abnormalities. The pathology here is the infiltration of the T lymphocytes, which gives you peritubular capillitis or tubulitis in these patients. So once they are given the calcinuric inhibitors, then we see that the patients tend to respond better. The therapy here is when you have AKI from acute graft versus host, then high-dose steroids are actually indicated for these patients. So a couple of questions you ask yourself whenever you see a TMA in this patient is, does the patient have infection? And if the patient has infection, then you need to control the infection. Number two, you ask, is it a graft versus host? If it is yes, then you have to give corticosteroids in these patients. Is it because of the CNIs. And if it is because of that, then you have to stop CNIs and add other agents so that you can prevent that. What about antibodies in these patients? You have to see if there are any complement factors which are present here, like C5b9. And if the complements are there, then you see you will actually have to continue monitoring. And at the same time, don't forget to give these patients adjuvant therapy in terms of antihypertensive. You also have to consider EPO, and minimize transfusion might make the condition much worse. So paraproteinuria-related diseases, this is a long list here of tubular disorders, glomerular diseases, and electrolyte disorders, but we'll focus on multiple myeloma because this is something we see a lot. So in multiple myeloma here, we know there is overproduction of the kappa or lambda light chains and heavy immunoglobulin chains. This tends to affect the glomerulus. They tend to affect the obstructive cast at the thick descending here, and sometimes you get cast nephropathy in these patients. So once you see these patients, then you have to classify them in terms of injury and susceptibility. So if your patient's urine albumin is less than 2 grams per day, they have cast, and then you can actually see they have Fanconi or tubular tubulopathy, or is it a glomerular disease where you have urine albumin, which is more than 2 grams per day? And then you have to think of, is it AL amyloidosis, monoclonal cryoglobulinemia, membranous? And once you see that, then you will actually decide on how to move on. When you look at the glomerular diseases, this gives you an idea of what you're dealing with. So if I have a patient who has a tumor of respiratory neck, and I'm seeing they are losing a lot of proteins, I possibly might be dealing with IgA nephropathy in these patients. If you have lung cancer, gastric cancer, renal. So most of these patients will require you to, at least, if they are not responding to treatment, to have a biopsy done so that you can have a conclusive evidence of what type of glomerular nephritis you are dealing with in these patients. Chemotherapy-induced AKI, we have a lot of anti-cancer agents, which are conventional agents or targeted agents or immunotherapies. Now, when you look at the anti-cancer or chemotherapy agents, a lot of them give you a different type of diseases. So if we are moving with cisplatin, so most of them will have TMAs in the kidney. If you're using pamidronet, you'll have a collapsing focal segmental. Cisplatin, fosfamide, zolindronic can give you acute tubular necrosis. Methotrexate will actually give you crystallization. Anti-VEGF inhibitors will actually give you a focal segmental or minimal change disease. Of course, we have ALK inhibitors here, which are going to cause pseudo-AKI in these patients. BRAF inhibitors, mostly used in melanomas, can actually cause acute tubular necrosis. Endothelial growth factor antibodies tend to cause a lot of hypomagnesemia. Interleukins will give you ATN. Interferons will give you also TMA and FSGS. Immune checkpoints are also known to give you all minimal change disease. CAT also will give you the same problem. So this chart is actually helping you to have identifications of what type of complications. A lot of patients we have seen with gemcitabine actually having TMA in these patients. Most of the patients who are on pamidronet have focal segmental, and you could actually see zolindronic acid causing acute tubular injury in these patients. So it gives you an idea of where the acute kidney injury will occur in these patients. Now, are there any preventive strategies in injury? in cancer. So I just took a couple of mostly used here, cisplatin, and cisplatin is actually one of the drugs used most of the cancers, starting from the neck, giving GI. So how do we prevent cisplatin toxicity? You have to hydrate your patients well. Of course, once you hydrate your patients, then recommendation here is also IV magnesium supplement between 8 to 20 milliequimoles may limit the renal damage in these patients. Now, recent practices and this mostly from small studies have shown that some of these patients are also put on the SGLT2 inhibitors, which also improve in the magnesium levels, and this prevents acute toxicity in these patients. Of course, in these patients also, apart from the hydration, we have to actually see that the patients are actually having good calculation of their doses and everything. Sometimes we get called in patients with cisplatin toxicity, and they want a nephrology review. And once we reach, we say we need to stop cisplatin and give maybe carboplatin or oxaloplatin. But what we need to understand is cisplatin is actually a curative chemotherapy drug, and curative chemotherapy drug is more superior cisplatin compared to oxaloplatin, which might have a little bit of reduction in acute kidney injury. But if you can approach patients by just stopping the medication, hydrating for a week or so, usually the kidney recovers much easier without changing the medication. At the same time, patients who are on dialysis, you need to discuss with your oncologist, because this drug actually can remain unbound for almost 24 hours once you give. Once you have given past 24 hours, then the toxicity will be very high. Now, in patients who are going dialysis, you can actually give the full dose of 100% dose, but then you need to dialyze 8 to 10 hours post-chemo therapy. So this needs coordination with you and the oncology so that your patients actually can prevent them from undergoing any complications. Okay. Methotrexate toxicity is also another problem, especially with osteosarcoma. We see a lot of high titers of methotrexate being given, and the dose is very high. But at the same time, we can do the same. You can alkalinize and also hydrate your patients before that. Of course, you can give your leucovorin rescue treatment in these patients, and you can also administer sodium bicarbonate in these patients. Now, there is a drug which is glucopidase, which is rapidly metabolizing the methotrexate to inactive compound and can reduce your plasma level up to 98 within just 15 minutes. But availability of this drug is a little bit difficult to get. So sometimes you will see patients are actually sent to hemodialysis. And hemodialysis in these patients, what it will do is it will give you the immediate effect, but then you can have a rebound effect because methotrexate is actually 50% bound and almost 90% is excreted in the kidneys. So how do you approach this if you're doing your hemodialysis? You might need to do more than one hemodialysis sessions for these patients to actually calm down the levels of methotrexate in circulation. What about radiation? Patients undergoing radiation also suffer from radiation-induced kidney injury, and you might find your patient at the start actually of the radiation, they start having increase in creatinine, increase in proteinuria. Some of them will have hematuria too. These patients tend to have hypertension, especially malignant hypertension, and then it continues for a very long time. So you need to see that when your patients undergo irradiation, what happens to the kidney is the tubules undergo tubulolysis and scarring, leading to actually kidney failure. At the same time, your glomerulus have mesangial injury with glomerular scarring and forming the kidney failure. Of course, this we are seeing a lot of patients now undergoing radiation who didn't have pressures now suffer from hypertension. In the other parts of the world now, we have a specific hypertensive oncology people who look at hypertension in these patients and try to catch them early before the hypertension can also cause more damage in these patients. Of course, you can actually see when you do the MRIs here, you will see that the capillary membrane, this is the normal one. This is the one which someone has undergone radiotherapy. There is expansion of these capillaries, and you find there is deposition also within the capillaries inside. And some of these are the ones which will cause you to have stiffening of these vessels and causing more pressures in the kidney. Of course, just to finish up, we have to now do some collaboration within different aspects of nephrology. We have to invite oncology. We have to be with radiologists. So interdisciplinary work group is very important for us to form as we move forward in onconephrology. I just go back to where we started with the EGFR problem, and people are working towards this problem. We have some tests here like the measured GFR where they are using the virtual fluorescent injections, which gives you very accurate GFR in patients who are actually on chemotherapy or have been diagnosed with malignancies. It is still in a couple of trials. You can see the subjects are just few, around 32 only. So we will keep watch and see if we'll come up with something which is better for us to get that. So with that, I want to say thank you very much for listening.
Thank you very much, Dr. Sood, for that excellent overview of onconephrology, the intersection between the kidney and the cancer treatment. So, if you have any questions out there, just write in the chat box, or you can raise your hands, and we'll allow you to ask a question. So, Dr. Sood, we're seeing more and more of these AKI, CKDs, electrolyte imbalances, and if you don't look for it, then you won't find it actually. One thing maybe I wanted to ask before anyone asks is, the AKI, we use a lot of immune checkpoint inhibitors these days, and things like pembrolizumab and stuff like that. And sometimes I've seen these patients get interstitial nephritis, acute interstitial nephritis. How would you treat, if you get AIN, secondary to a checkpoint inhibitor, what would you do?
Yeah, so correctly said, especially now that we have these checkpoint inhibitors, we are seeing more of these cases coming in. And correctly said, the electrolytes is where we have most of the problems. So in these patients, how we approach them actually is with checkpoint inhibitors. So, most of them, number one, we look at what are the other factors which are causing them to get the AKI. A lot of these patients, we find them completely dehydrated. As I said before, after they are given these medications, they tend to have diarrhea, some of them vomiting, sepsis. So you have to address that first. Number two, then look at the dosaging for these patients, if it's actually good dosaging for them, or if they have already suffered from that, then you have to actually give them a time to to actually stop the medication and see how they will respond in that. Yeah, so that's how we'll approach it.
Yeah. Okay. So, stop the medicine, and then there might be some role of steroids if things don't improve after stopping the medicine, and maybe some other immunosuppression. I think I have a question up on the box. Use of nephrotoxic chemotherapy or immunotherapy, still risk is high, and if pre-imperative treatment with steroid treatment can allow us reuse and decrease the risk of okay. The question is a bit I can't
So
really understand.
So
Can you
I think what he's asking if we can give steroids prior to developing AKI in these patients. So the answer is actually no. We don't use steroids as a preventive measures in these patients with cancer or chemotherapy-induced nephropathies. So what we need to do is, one, we always look for what is the underlying problem. Why did they go into AKI? Rectify the identified problem. And if it is something which can respond to different alternatives. So like if a patient suffered from interstitial nephritis, steroid will help to reverse. If a patient suffers from TMA, eculizumab can actually work to reverse that. So whatever the underlying problem is, then you can intervene. But we have not seen data showing us that if you give steroid pre-chemotherapy, you might get away with AKI. But we have seen if you give fluids pre-chemotherapy, you might reduce actually the risk of AKI in these patients.
Thanks, Sud. I think Abdul Hamid is also asking in TMA secondary to VEGF, when to use plasma exchange or complement inhibitors. I mean,
Yeah.
you mentioned about eculizumab, but
Yes.
yeah, just expand on that a bit more.
Yeah, so yes, you can use eculizumab if it's available. There are anecdotal data showing that it works better in these patients than taking them through plasmapheresis. But I mean, we don't have concrete evidence in terms of which will be actually reduce the mortality completely. But if you have an option of any of the two, then you can use.
What about plasma exchange? Should you have any experience about plasma exchange for TMA in VEGF inhibitors?
Yes, so plasma exchange actually can be indicated for these patients. You can actually do plasma exchange in these patients.
Great. And I think now plasma exchange is widely available all around the country, as well as, it can be probably available. Nowadays, if you have a normal dialysis machine, you just need to get a plasma filter and you can do plasma exchange. So it should be available all over Africa. I mean, this is an Afran webinar, so you're talking to people not only from Kenya, but all over Africa. Dr. Sud, it's been a great pleasure to moderate this session and to listen to your excellent talk. I'm just waiting for any other questions. I can't see anything on the chat box. So before I close, any parting shot, and then we can close the webinar.
Yeah, I think one thing, this field is new, and we shall see a lot of AKIs now based on the drugs are coming in at a very fast rate of chemotherapy, more than what we have. But every morning you find a new drug coming in. I think we need now to have a multidisciplinary team when you are dealing with cancer patients, so that we can have very well-informed management of these patients before they go into complete renal shutdown requiring renal replacement therapy. What I've seen is one of the simple medications like magnesium is what we tend to underestimate. But in patients with cancers and chemotherapy, magnesium therapy actually helps very much in scavenging and antioxidation at the mitochondrial level. And this is where all the problem starts when you dive into the pathophysiology of all these injuries. So I feel we need to look at this data very well. I talked about SGLT2s now coming in, patients who are on cisplatin, if you can give them so as to protect, again, antioxidants and also preservation of the magnesium channels in these patients. So yeah, that is something we need to look at.
Thank you very much, Dr. Sood, and I can't agree more to that. It's a multidisciplinary effort, and don't just prescribe chemotherapy and let these patients get their chemotherapy without monitoring, their renal functions, their electrolytes. Looking at the urine itself, if you find any protein, any cells which are abnormal, then just alert, have a discussion with the nephrologist so that you can prevent further damage. So thank you very much. Thank you everyone for joining in. We had a great discussion and a great talk. We are having our next webinar, actually, Dr. Mazhar just informed me, with the Afran Clinical Nephrology Committee. We are most likely having our next webinar on, the first week of March, 5th of March, on membranous nephropathy by Professor Feziva Bisiwe. So we hope, we'll see you there again, all of you, and have a great week. Thank you very much.
Thank you. Thank you.